Muy buenos días a todos y todas y bienvenidos a la sesión de hoy de esta serie de seminarios virtuales sobre opciones de políticas para fortalecer y transformar los sistemas de salud en las Américas. Mi nombre es Claudia Pechetto, soy asesora en Economía de la Salud y Financiamiento de la PSOMS en la Oficina Regional de Washington. Es un gusto para mí moderar este seminario virtual. Este es el segundo webinario de la serie sobre opciones de política para fortalecer y transformar los sistemas de salud en las Américas, organizado por OPS. Y en esta oportunidad es un evento especial, ya que se desarrolla en el marco de la Coalición Temática sobre Financiamiento para el Desarrollo, una iniciativa regional que une a todas las entidades de las Naciones Unidas para avanzar la Agenda de Desarrollo Sostenible 2030. Antes de dar comienzo a este evento, quisiera comentarles que estaremos ofreciendo interpretación simultánea en los 3 idiomas, el inglés, español y portugués. Por favor, elijan el idioma apropiado para su conveniencia. Para ello, pueden escoger aplastando el botón en forma de globo en la parte inferior de la pantalla de Zoom. También contamos con subtitulado para las intervenciones de los panelistas y puedan seguirlo de manera más conveniente. Pueden activar esta función en el botón que dice CC, también en la parte inferior de la pantalla. Les recomendamos también ajustar la disposición del video en Zoom al modo lado a lado y así poder ver en una misma pantalla las presentaciones así como a los presentadores. Por favor, tengan en cuenta que pueden enviar sus preguntas y sus comentarios en cualquier momento del seminario a través del chat, que se encuentra también en la parte inferior de la pantalla. Y por último, les recordamos que mantendremos sus micrófonos apagados para facilitar el desarrollo de esta actividad. Sin más espera, para dar inicio a este seminario,
This activity. I have the pleasure to welcome our first participant, who will introduce first context, Daniel Tillman, who will introduce us to the context of this seminar. Can you hear me? Good morning. Well, thank you very much for being with us. In the name of the Coalition for Financing Development, which we coordinate with Luciana Bermen, who is the other coach. And while it's a pleasure to work with all of you on different issues that have to do with the financing challenges that our countries face in order to reach a sustainable development in the future. And this seminar today is very relevant because we're going to talk about the central issue among the many challenges of our continent. So we thank Julian James for their efforts to organize this seminar. And this goes for thinking of the future after the pandemic, of thinking about resilient and inclusive health systems and the challenges we are facing in that sense. This seminar is essential in order to discuss not only financing, not only from the perspective of financing, but also how to face the structural divide and all the issues that were increased by the COVID crisis that also left us with some challenges for the future that we will have to face by developing our health systems. So in the name of the Coalition for Financing Development, we would like to welcome you all. We believe that this seminar is relevant for a region today and in the future. Thank you, Daniel. For us from PAHO, it's a great honor to have you with us. And as you mentioned today, Financing is something that always gets a lot of attention, and it's very important because, as you know, resources, as you all know, resources are very scarce, and financing means putting together the resources and uh, at, and assigning them to the needy areas. So in order to debate, to open the debate, we have invited Dr. Fitzgerald from the PAHO organization to share his presentation about financing health systems in the post-pandemic area. James is a PhD in pharmaceutic sciences, and he has been working with PAHO for more than 20 years. He is a director of systems and health services and systems. Thank you, Claudia, for this introduction. It's a great pleasure to be with all of you today, this morning. I see that we have a lot of participants. I see all the greetings on the chat from North America to the most southern countries of our continent. And I have a special greeting and thank you to the panelists that we have today with us. We have a very experienced panel with Oscar Midori, with ministers, well, and of course, with Danielle, our colleague and friend. So my presentation today is focused on health issues and health financing mainly, because this is a key factor for the resilience of health systems. We will go into financing in a wider context about what has happened and what should happen in the future in order to create resilient health systems. I will, well, I know that we have a very diverse audience today, so I will go over some concepts that have to do with health financing and in the context of the pandemic and after everything what has happened, and the strategic issues and decisions that were made by the countries in the context of PAHO during the last 12 months. So with this structure, I believe it's very important, and when I won't talk for a long time because we have had many presentations about the effects of the pandemic, but there is some information that has been made explicit by Daniel in his comments. The fact that this pandemic has amplified the inequalities, especially among vulnerable communities. In the last 2 or 3 years, we have done many polls in the countries, and we have studied the reaction to the pandemic, and we have seen that this pandemic has brought on a lot of trouble for basic services also. And during the period of 2020-2021, we have experienced a huge crisis, and we are trying to recover from this huge wave of morbidity and mortality. And so the systems have suffered a lot during this period, with a great impact on access to health services. These impacts have been on the demand side, but also on the supply side. The population, the concern for the population to have access to health services, to look for the necessary medication, and also the offer, and on the side of the supply side, we have the problems of reorganizing the services in order to tend to the needy, especially during the pandemic. We are very concerned with what has happened, and we need to think how to build resilient systems that can provide palliative services, and also normal services such as immunizations, etc. So we'll have waiting lists in all countries. We have a lot of non-satisfied needs and barriers to access. And we have seen a great increase in disease and death in our countries. We want to go through some of the concepts of the challenges we're facing. What does it mean when we say resilient health systems? This is not the first emergency, health emergency that we have faced in this region or in this world. We have gone through several very difficult times in the last 10 years, especially going through the risks of Ebola and then Zika. And in our work, in our daily work, we have seen that we had to prepare health systems for crisis several times, and we have seen that our systems are not resilient. What does it mean when we say resilient? These are well-developed health services that can um, involve a series of actors, and in order to work together facing a crisis and to respond in an effective manner to the crisis by maintaining the basic services at the same time. And then the capacity to recover and improve their services based on the lessons learned. This was the decision, the definition that was adopted in 2016. And we distributed this document to the health systems in our region. There is a great challenge to reach this resilience, especially regarding the segmentation and fragmentation of the systems, the lack of capacity of certain populations that cannot go from one segment to the next in order to have access to the services they need. And this, it's a fragmentation not only in services for comprehensive care, but also the possibility of responding to needs afterwards, after a crisis. So if uh, we have to put together different elements from the structure to the different functions of the systems, from organizing services and keeping up the quality of the services. And in the policy context, in the political context, we also need to respond to comprehensive needs. These are the key elements of a resilient system that can adapt to crisis, but can also recover from crisis and restore normal service and keep up normal service. In this resilient concept, the resilience concept for health systems, what are our challenges in the Americas? First of all, we have two main goals of financing in universal health, and two key elements: equity, and efficiency. That means equal service for everybody and efficiency in our services. The universal health strategy that was adopted by all countries of the Americas, there was an important census that put together finds the concept of financing health. That was to increase public investment in health with equality and efficiency towards sustainability and predictability in order to ensure an appropriate response, especially focusing on vulnerable populations that need more support in order to respond to their needs. As was mentioned by Claudia, the three functions we know about, the three functions of financing health are are getting income, this access to income, especially through um, public means, 6% of the GDP, equality and sustainability. First of all, we have to increase this in public investment up to 6% of the GDP. We believe that private investment is inefficient and cannot face the main challenges of health crisis in the Americas. We need to establish also sustainability and equal service. And we need to pull together the financing sources in order to ensure service to the general population. The main challenge we have is segmentation regarding the putting together of risks or the risks and income. That is to make these mancomunate issues. If we look at the analysis regarding the public assignation of resources to health, we see that there is what we call a void investment, an empty investment, which is empty expenses that are those of the private sector in this. We see an improvement in health services when 6% of the GDP is assigned to health services. But only a few countries are reaching this goal. But there is an important movement during the past years towards this quadrant that shows that one can successfully face the challenges of universal health care. We need coherent policies regarding the structuring of health systems and health services in general. And as I said, it's still insufficient. And when we see the trend in health expense, um, it's about 6.8% in general, but it's by putting together public and private investment. And our conclusion is that private investment in the region right now is not very effective because we often hear the countries say, oh, we have achieved 6%. But when we break this expense down between private and public, there are just a few countries that are getting to the public investment of 6%. There was a trend of for the increase of public expense on health, but there is what we call the empty expense. Usually, the public expense in health um, um, means that we have to reduce the empty expense of the private side. And if we see this on the capital side, a per capita point of view, well, this was before the pandemic. It's even more important. During the pandemic, we have seen that it has become even more urgent. Now, the fiscal capacity is very important, the fiscal space. We need to not only um, uh, get the income, but also to assign it. We have to assign the resources in an appropriate manner. We see that the priorities of the countries are not on the essential services. It's too low. The priorities are on other issues. And we have to articulate this with discussions about financing and also the legislative part in the individual countries. I already mentioned segmentation. Segmentation, it's a great hurdle in our region. It's a great difficulty. Um, Here we see the division between funds from Social Security, general government income, and also private sources, that is the expense of the population and private insurance and other private sources. And this means that these health systems are the health systems in our countries are very much based on private investment. And this is to be seen in all countries in our region in a strong manner. And then we have the mixed financing systems between private and public sources. And we have two extremes here. The red line with the countries that do investment that is above 6%, and countries that the countries that have um, other other systems like those based on general income, like in this case, Costa Rica, for example. Here we see great inequalities in the results. When we observe, well, when we were struck by the pandemic, we saw a strong trend in financing. We saw a lot of external financing between March 20 and July 22. More than 300 operations, that means disbursements or loans. This means that we have 70% of financing that is related with COVID-19 and 18% for the sources. During the first quarter of this year, the investment was only $1 billion, which is a great reduction. It's a little bit early to see what is happening with the income for the health sector. With these issues, we're facing now certain questions about the capacity to sustain the health services in the context in the precarious fiscal situation, and how the countries are right now trying to impose reforms on their health systems. In this context, what are then some of the strategic recommendations that we could see here in the region of the PAHO region? When we define our roadmap, what do we want from our health systems in the future? The countries responded that they want resilient health systems that can recover the progress made before crisis, and trying to overcome the inequalities in service as during the pandemic. And secondly, we want to do reforms in our health systems in order to expand coverage with an important focus on equality of service, of fair on equal service. And we have to prepare and improve our capacities of response before public health emergencies. This means leadership and guiding and governance and financing transformation of health systems. Then the countries adopted a new strategy in order to develop resilient health systems. This was during the council last year based on the analysis we submitted last year. What steps were adopted? First of all, uh, there were substantive transformations based on primary healthcare. Second, to strengthen the leadership in countries, to assign the necessary resources. Third, to build networks, comprehensive networks, and to improve access and to make response more effective in case of emergencies. And fourth one, which is the issue here of this webinar, is to increase and improve public financing by integrating health actions with financing. I would like to go through these points because all of them have um, consequences in terms of health. First, we have the transformation based on primary health care towards universal health care. So we need to promote the recovery in short-term recovery by facing structural gaps in the medium term. And we need to promote investment in health, in people and communities in preparation response to health emergencies, and also to promote equality in access in order to care for the needs of most vulnerable populations. We need to renew the commitment to the to the PAHO Pact of 6% of funds invested, public funds invested in health. Second, we should try to strengthen, we should strengthen the capacity of public health capacities through the essential functions of public health. We need public health as a strategic axis in health systems. We need to improve the capacities and designing and strengthening structures and institutions so they can coordinate different interventions and programs in public health, and to strengthen the four priority areas of essential services. Um, we are making progress on our roadmap to strengthen public health systems in these essential functions. And in the third place, we need to strengthen the capacities of integrated networks in health services. We need to organize and integrate individual health services and to base them on the population. We have to focus on first level care and specialized services, and we need to assign the human resources, the information system, the medication and technologies and financing. All of these has to be aligned in order to strengthen the capacity and the efficiency of integrated healthcare. And there is an axis that goes through all these issues, that is to increase public financing of health and social protection. It has to be a sustained investment, creating the necessary priorities and investing on essential services, assigning resources to the first level of care and improving efficiency in expense in order to improve social protection. Well, Claudia, thank you very much. I will stop here. It has been a very important opportunity for me, and I see that we have to really focus on these issues. This allows us to have a strong focus on these issues in the region, and that we can feel the pressures and the challenges. Uh, and in order to tell you about these issues, we have invited Daniel Peterman, who is an economist from the University of Los Andes in Colombia, and he has a master in political sciences from Flaxo, and also from the University of California in San Diego, and he was a coordinator of the unit of special studies in ECLAC, and he's a specialist in monetary policies. Daniel has a lot of experience in macroeconomic issues and has published a lot of articles on these issues. Thank you, Daniel, for accepting our invitation, and welcome. The mic is yours.
Thank you very much. And first of all, thank you, Claudia, and thank you for, you hear me, right? And thank you for the invitation to comment on the excellent presentation that James gave. I'd also like to say hello to all the friends that I see on the screen. It's a pleasure to see you, even if it is through digital mechanisms. We hope we can do this in person soon. So I also say hello to Daniel and all the friends. I don't want to name them all because I don't want to use my 15 minutes for that, but thank you very much. I wanted to take advantage of this excellent presentation that James gave to try to highlight and go into depth on some of the topics that he mentioned that I think are very relevant towards the discussion that we will have. Mainly, James, well, is telling us first about the big challenge of building resilient health systems. And we look at this through the perspective of the organization of the system, the priorities that we have to give, public care, more complex care coverage, and the challenges that we have in financing and challenges of demand. But I'm going to try to focus on financing. It's not that the other topics are relevant, but given the goal of this webinar, I'll focus on financing. So I would like to start by saying that indeed, when we talk about resilient systems, we have the question, resilient related to what? Because as James said, we have this big challenge of working towards universal coverage with universal care. It's not just to make access universal, but we also have to make the service provision, or so what I mean is real access. And this, along with all of the reorganization that James mentioned of how services are produced and provided and also financed, it also, in my opinion, leads to a question. And the question is, how should health systems be financed so that they can be resilient? And James was showing us that there is a mixed relationship in the region with a high percentage of private payments, which is something that is the most excluding thing that we can have as a barrier of exit. And there's a mix of public sources that James was saying, social security and other general income from taxes, and then private insurances. And he was also talking about the volatility of external sources. I'm going to focus on domestic sources because these are the essence to build and finance a resilient health system. And in terms of internal financing of health systems, as James was saying, and this is true, the systems in Latin America are underfinanced or poorly financed. And this is complicated because when one looks at the dynamics of the expenses of health, these are growing, and they're growing growing much faster than economic growth. So this leads to more gaps than we have. And universal health does require some certain expenses, and it requires resources. So this becomes important in we also have to consider the demography transitions that we have in the region. And one could forecast that the demand for health services is going to grow in time. So how does one take care of this demand of resources that is growing in these contexts of fiscal restrictions, but also in a context where the region is not going to be growing as much in the coming years, and this also affects the ability to collect resources, income. So Daniel gave us an important challenge, and that is how does the health sector or the evolution of the expenses in health will compete with other expenses. So here we have a database of functional expenses. We have, for example, in terms of function, it's divided into functions. And as James was saying, there is a growing increase in social expenses in housing, education, pension funds, for example, and health. So when one looks at functional expenses, not the economic classification, but the functional classifications of expenses, we can see that in average, the countries are at 2.5, 2.4, 2.5, and the WHO has 3.9. In both points of data, we are very far away from the 6% that James is bringing. So the question is, how do we advance in our capability to finance health systems, along with all the reforms that we have to do to rationalize the use of resources? Because James brought something very important to the table, and that is efficiency and equality. Equality meaning universal access to health. And in my opinion, efficiency has two elements: the service provision. How do we improve the provision of services, maintaining costs? Because if we don't, costs could explode. Health is a sector that is very special, and any technology development makes costs more expensive. It doesn't reduce them. It operates in sort of this increase with way. And the more technological sophistications we have a higher demand of resources. There's higher costs. So we have to contain costs. And James was talking about this within health systems. And we also have to think about how to increase financing, and especially how to improve the composition of the financing. Financing cannot be increased through greater private expenses, because this is completely excluding, but we also can't think about private insurance. So we have to ask, how are we going to organize public spending? Through social security and through other general sources of incomes. And in my opinion, this is one of the big challenges when we talk about resilience in health systems. How are we going to evolve the social security systems and the public financing systems and integrate them so that we can advance in this sort of efficiency graph that James was showing? And we have a big challenge there, because we're thinking about mixing collection systems with public financing systems. And this is a segmentation that the region has. But this is the starting point that we have, that we live with. So I'm going to focus on these two axes because we believe they're the main axes when we talk about resilience of health systems. And here, I'd also like to talk about a complex situation, because part of the costs and the effects that we are getting from the COVID crisis, that is also joining the crisis of the war in Ukraine, is a slow recovery in growth with a big delay in the recovery of labor markets. We're seeing that labor markets are very slow in reacting to the growth of the GDP. And with this leads to more problems in the growth of employment and unemployment rates, which directly affects collection systems. In turn, as James was saying, there's lesser fiscal space. So this is a situation that we have, and we have to take care of when we think about building resilient systems. And we in CEPAL insist that maybe the big challenge that we have ahead of us is how to expand the fiscal space so that we can increase expenses with fiscal sustainability. And we believe that this is a big challenge that is not just for the public sector, it's for the fiscal policies in general. But it will be affect the health sector and also the public investments. So I think that a big thing that comes up when I hear James and CEPAL shares this, and we have been advancing in this work, is that the big challenge that the region has is not how to contain the expenses, but how to generate an expansion of expenses, but in a form that is sustainable in time and efficient. And this implies two things: taxation and fiscal expenses. Well, we in the countries of the OECD, we have low taxation rates. The taxation rate with high heterogeneity is about 22%. And countries that go from 12.4, like Guatemala and Barbados, with 35%, Argentina 30%, Brazil 32%. So but the average of collection in the region is low. And it's not just low, it's also regressive, because 50% of this is indirect collection, tax collection. And this is a regressive structure. So we have a big challenge on how to increase tax collection, not just the load, but also the progressivity of the taxation structures that we have. And we have a lot of countries that when you say they have reforms, the first or the essential point would be the taxation reform that has to accompany that other reform, because a resilient health system has to maintain, well, this famous dogma: permanent expenses require permanent income, and health systems are permanent expenses in time, not per individual, but in terms of a society, it is a permanent expense that is growing and will require permanent income in time that can be able to finance that growing expense. And this is a big challenge. We have proposed this in different areas, and so we have to think about how to expand fiscal spaces, increasing fiscal incomes. So once you advance with that, then you have to talk about prioritization of those incomes to generate the circles of care. And this is the issue of how to expand expenses in health. And the other thing that we have to look at is we have to expand the contribution expenses, that incomes that go to health. So in terms of that, in our countries, we have a low roof, and they will advance in terms of improving productivity and levels of employment. Otherwise, that will hit a ceiling, and it becomes a very heavy load to salary. So part of the pressures that we have in the coming years is in the public incomes of general taxes. And that is why I want to insist that, in our opinion, fiscal sustainability to allow greater expenses in health are a cornerstone of building resilient health systems. We believe that they will play a central role. The other thing that we think is central, related to what James is talking about, and I'm going to finish with this, is the organization of solidarity. In CEPAL, we have been saying that if one wants to go to universal coverage in health that is effective, and of course this applies to other social policies, we have to have solidarity. And this is an open discussion in our countries still, of how to organize and how to finance solidarity. So the question is, if solidarity is going to be organized incorporating contributions or just through general taxes. And in our position, solidarity should be financed both through contributions and also general taxes. And when one starts to think about the way that one is going to finance the mechanisms, how to redistribute mechanisms to have that component of solidarity that all health systems require, It's not just solidarity between those who are sick and those who aren't, or those who are older and those who are younger. It's also a way to think about financing. And many of our health systems do not permit solidarity in financing. Or maybe they're completely addressed to financing the public sector or public institutionality, or because they have a segmented solidarity in social protection systems. And I think a big essential challenge that we have to advance towards resilience in health is how are we going to finance solidarity, and how are we going to integrate the risks of health in the population? If we are segmented, as James was showing, this means that the financing mechanisms will also be segmented. Social security is segmented into social security, and public financing that is directed towards institutionality and public health is segmented. And a big challenge, given the need that we have to increase efficiency and solidarity, as James was saying, is to integrate the risk structures in society to be able to do this in a context that is always going to have scarce resources, even if we improve. So to finish, I would say that what I would like to emphasize out of the excellent presentation that James gave about the challenges in the region is resilient health systems require stable and predictable public financing. That means that we have to increase the fiscal space through taxation reforms that allow us to sustain growing expenses with growing incomes. And this doesn't mean just to increase the taxation load, but also to improve the structures of taxation schemes. And the second one, given that we have segmented systems in many of our countries, segmented between social security, private expenses, and public expenses in health, how are we going to integrate those sectors in terms of financing, at least, to be able to finance solidarity using all the resources that we have at hand? Thank you very much for being able to share with you, and I'd like to again congratulate James for his presentation, and I feel very impressed. I see that we have 465 participants in this webinar, so that's very impressive. Thank you. Thank you very much, Daniel. Thank you for very brilliantly landing the challenges, grounding the challenges that we have in the financing systems, as James described them in the region. And according to what to do in those two functions, recovery, increasing fiscal steps, and then also how to integrate and how to dissuade the segmentation that we have in this region systems in terms of how to finance resilient systems. And to have a broader reflection, we have invited 3 very special panelists to this webinar. They're all experts in the region, and they will share their opinions about the challenges that the region has to establish resilient health systems, specifically the challenges that are related to financing. That is what is bringing us here today. It is a pleasure for us to have the presence of Daniel Olesker, Midori Dehavich, and Oscar Cetran. And we are going to begin with Daniel. Daniel Olesker is a magister in economic sciences, graduated from the University of La República and Loyola, a new university in Uruguay de la República. And he has a 5th degree in UDELAR University. And between 2010 and 2011, he was Minister of Health, led the health reform in Uruguay. And between 2011 and 2015, he was Minister of Social Development in Uruguay. He is currently a senator for the country. Daniel, it's a pleasure to have you here. Thank you very much for accepting our invitation again. The floor is yours. Well, thank you very much for inviting me. It is a pleasure, as Daniel said, to be with so many people listening. It's a pleasure to be spending time with James and Daniel Tichtelman and Oscar. And I'd like to tell everyone that the reform in Uruguay was successful because when we invited him, we told him about how we were going to do the financing reform, and he gave us 2 or 3 perspectives that we didn't have back then, and we used them, and they were very good for our reform. So I'd like to thank Daniel. It's a pleasure to have him here. So I have 3 reflections and 5 points within my time. The 3 reflections are following. First, this was said by James and Danielle, health cannot compete with the rest of social protection in terms of financing. That is a wrong vision that is fragmented from the past. It has to be part of social protection because it's hard for a health system to be resilient if people live in precarious homes or if the levels of education are showing us high levels of detertion. So we have to think of social protection as a whole, and that's very important in financing. We considered this in our reform. The second is that we have to, in terms of segmentation, finish with that discussion of genuine financing. What is genuine financing in Social Security? The contributions of liabilities to do assets, we have to look at the general income, and then depending on the social and political and health priorities, we do the distribution. And the third is that, as James said, and James showed a graph that made it very clear, the indicator of health as a percentage of GDP is a bit of a liar because it only measures the efforts, the global efforts. But what matters in the distribution between public and private, and this is what we did in Uruguay, that we had a great increase in financing, but the relationship with the GDP was still 9%. So what changed? The distribution between private and public, which was 2/3, 1/3, and then it flipped towards 1/3, 2/3 private, public dominating. So this is the stuff that I wanted to mention. Now I'm going to try to provide some ideas about the points that are in the document that is very good. Well, it's a document, and with James, we worked with a group of experts in 2017 and 2018. And the ideas that he presented today, he brought to that group, and they were very useful for the group. So the first point is, I think that having a discussion about the fiscal space, because if we have this ideological building about the fact that there is a limit, so we have to think, is there a limit or is there not a limit? So, as I said today, what matters is the total global expense, and then to think about how we prioritize areas. So it's clear that in James' graph, and Danielle mentioned as well, with the current fiscal pressures and the public expenses of GDP in the region, we can see a possible reform. So we have to expand the fiscal space, and that has of course, a very objective space of capability to expand, but it also has a subjective part that Daniel mentioned, and that is that in Latin America, and Uruguay did this in their reform, was this middle step, and that is a taxation reform, and in volume and composition. In Uruguay, we had 70%, and now it's 48% of the sales tax. It's still important because there's an important change, because we had progressive taxes that were introduced, and I would say the financing for the health system within that. And I share, there's something that Daniel also mentioned that I share, and that is that we have to think of systems where the contributions and the general are associated. And each one, of course, would have its own mechanism. We have our own. The second point that was also proposed by James in his presentation, that is key to unite funds. We had a discussion in the group, funds to join the funds, because someone has to pay for solidarity. Someone will have to pay for solidarity. And in my opinion, the only way to be able to pay for solidarity is that fund, one single fund, and that fund is sustained by incomes. I don't see any other possibility for this. I repeat that funds will be contributions and will have general incomes. Well, this will depend on the place, but that will have to reduce the load of direct payments. So I think solidarity is key, but this is a solidarity that, as James said, sorry, Danielle was saying this, is triple, because it's solidarity of the income of the population and the provision of in the ages of the persons, and also in the diseases or illnesses. In, for example, a continent where we have a lot of non-transmissible illness, so the load of that, or the weight of the diseases, is very high, or illnesses is very high. The third point is something that is also in James' document, and that is the challenge between balance and efficiency. A joint fund that is betting on social justice and solidarity has to integrate towards a system of provision of health services that provides the providers, public if it's easier, if it's public and mutual or social, it may be a little harder. And if you integrate private parties, it's even more complicated, but you have to make sure that the resources that those providers from that fund have a certain level of efficiency. And for this, in my opinion, we have to consider two variables. One that was proposed by Daniel, and that is the risk that is associated to the illness. And the other one that I think we should discuss is the stimulus for complying with certain objectives. We could call it payment by goals. It's called something different in Colombia, but it exists in many countries. And not any goal, goals that are related to the main health problems of the population. We did a payment per goals, and we focused in children and pregnant women. Today we have different things because, well, we've evolved, but back then those were the main health problems that we had in our country, and also the main social problems in general, not just health. And so that's my third point, balance and efficiency. The fourth point that is also related to efficiency is the distribution of the money. How do you distribute that financing? Here we highlighted, and there's even some numbers that we have from back then, how the 6% of on GDP, how the 6%, out of that 6%, 30% was going to primary healthcare. I think we're very far from that in general terms. I believe that the pandemic also has made this problem more acute because it generated a policy for concentrating resources in secondary and tertiary levels of care and not in primary care. And here we have an important problem related to public policies. We have to finance general policies, particular specific policies for primary care, and we have to socialize these catastrophic expenses. So the high price, low prevalence expenses that should be socialized into that joint fund. And to finish, finally, the fifth and last point that was also mentioned by James is the human resources for a system like this one. The experiences that I at least know for the countries in the region and for Uruguay, something that the situation that we have in Uruguay and is that the distribution of human resources really obeys to the market of payments. So if there's a distribution of resources that more or less accompanies, is in the medical cases, the specializations that are paid most, for example, in nursing, in Uruguay, it's the secondary and tertiary pay more than primary. So I specialize in that because I will have a surplus in that. And that leads to distribution. And we also have to think of the territorial distribution of human resources and their payments. This was my 5th point. And to finish, I just want to say that the reform in Uruguay advanced very much in the first 3 points, and the last 2 are still a challenge for us. The distribution of human resources and expensive. So universality, efficiency, and equality did advance. So I mentioned these 5 points because I think they reflect are reflected in the presentation that James gave, and they can help us with health reforms and this is reflected in the health reform that we built in 2008. Thank you.
It's a pleasure to have heard you, Daniela. Thank you very much for your comments and for stressing the factors that are so important for healthcare, such as human resources, for example, and the need to prioritize also. And the reflection, your thoughts about who pays for solidarity, which is the center point of all the great reforms that we have to carry out in the region. Thank you again. And now we hand over the floor to our next presenter, next commentator, Midori Habich. She is now the technical director of the local healthcare system at UNDP, and before she was the Ministry of Health in Peru, and she coordinated several projects for strengthening the health system. She has a master's degree in economic policy, and Daniel and Midori have a common trait. They both have been ministers of health. Thank you, Midori. Thank you for being with us. Thank you very much for the invitation, for the opportunity to be among people that have not only knowledge, but a lot of experience in these issues. And I'm right now noting down a series of ideas that we have to talk about later also. Your presentations and comments have been very complete, excellent, and I'm excellent, and I'm sure that all participants will be very interested in receiving your presentation. Now, some comments. The very challenging agenda that James has put before us, and also the two Daniels, is an agenda that we have been discussing for a long time. It's not necessarily a new agenda. However, there have been some very important changes, conditions that have changed based on the pandemic or after, originated from the pandemic. I wanted as we are talking about financing, I wanted to mention, I don't know how sensitive actors are to the actors that manage public resources, how aware they are of these issues after the pandemic. The logic would tell us that we have never been so much aware of the relationship between economics and health, and it should have been made, you should have raised awareness also at the ministries of the economy. And but however, well, and there have been additional resources to health ministries during the pandemic. But this section, will it be restricted to the pandemic? What are we seeing now? We're still in the aftermath of the pandemic, and the ministries of the economy have been restricting resources already. Again, how can we make it clear to them that this clear relationship between health and financing uh, is lost to them? How can we make it? Uh, how can we make them aware? Um, it's not only related to COVID, it's also related to structural problems such as human resources, logistics, etc. And well, know what I want to say. Uh, After the pandemic, when the aftermath of the pandemic, the resources already starting to dwindle. And this is the first issue that I believe is very important because it is an opportunity, at least theoretically or potentially, and we have to try to maintain the focus of priorities on health because it's a fundamental issue that should be on the agenda as also as a lesson learned from the pandemic. And there have been countries where the labor market is informal, and the lockdowns and all the policies that affected the economy and the families were focused. Well, in Peru, for example, we have 75% of non-formalized labor, of informal labor. And the situation of these families depends on these informal markets also. Um, so the pandemic also had a huge impact on the labor market. This should also lead us to new thoughts about this. And we have to look at the health agenda with a greater relationship with also the economy. And the third thing that I believe is important, it's not new, but we should stress it much more, and it's the relationship between public health and primary health care through the usual services. We have, my perception is that we have spent a long time discussing universal health, universal access, etc., but it wasn't very clear in that scheme. We were talking also about the need to strengthen public health and emergency response, etc. And as I have heard at PAHO, that level of public health and emergency response is a key factor of universal health care. So that link between emergencies and primary health care becomes much more clear when during the pandemic. These three issues are to be seen as opportunities, as challenges, and we should not lose sight of them and reassign roles and means um, about primary health care and how to integrate also these social determinants of health that depend on each situation in each country. After having said this, I would like to go to our next point that I have been working on during these past times, and that's something that everybody has mentioned. It's prioritization. Won't go into tax issues because we all agree. I won't be adding anything that can improve our point of view. Uh, but to put together public resources, how are the well, how are we assigning public resources to priorities? What's the relationship between public resources and priorities? We should define our national priorities in a clear and participatory manner. In some countries we see that, but in other countries we don't see that. There is no participatory process in defining priorities, but even those that have an institutionalized process, uh, in the countries that I have been talking to lately, we see a disconnection on the between resource allocation and it's very difficult to modify the programs of public ministries, of the state ministries. And when we talk with people that are concerned with the allocation and execution of public budgets, that manage our public budgets, that are based on financing and economic rules, when we talk to these people, they say, well, a good public expenditure is the one that is assigned to priorities. So if we look at those that plan priorities and those that assign resources, I believe that they have to get together to set clear priorities and transparent ones so that the population knows about these priorities and backs them and agrees with them and the resource assignation. Because, well, if there are no resources for these activities, we're not talking only about priorities, but about needs, basic needs in the budget. This is an important point. I believe also that after the pandemic, in with these conditions that we have been in, well, this leads me to think that in some countries, Peru is certainly it's certainly the case. We need to reflect on our priorities and make sure that the resources are gradually and progressively um, assigned to the right places with due monitoring and um, improvement in logistics and infrastructures, etc. If we weren't in this schizophrenic world, we say one thing, but we build huge hospitals on the other side. I don't say that huge hospitals are not needed, but what we need primary health care. Of course, we should look at the priorities from a more universal point of view. We should profit from this crisis and these difficult economic situations we all face in our countries. We should say, well, the resources will still be scarce, will continue to be scarce. We can increase them gradually, but not right now. So there's a need to say, okay, What are the things that have direct influence on the population's welfare, and what's the role of healthcare here? It's obvious to me because when we talk about primary healthcare, and we have talked about primary healthcare for decades now, we're still debating what does it means, what the concept means. But we do have converging ideas about what it should include. So why is it so difficult to really make this an effective priority and gets the necessary resources, and so we can redistribute resources in this sense? I won't talk about incentives. We all know that incentives are is looked at from the wrong point of view, but we need to launch this initiative. Without primary healthcare for the population, we won't be able to strengthen the primary healthcare. How do we achieve this? Well, it's a political issue. It's not only technical. I repeat, from the technical point of view, most of public health experts are convinced that this is a priority, the great majority of them. But the people that have to look at it from the social point of view are not focused on the benefits, are not aware of the benefits really. The distortion of our own health system um, uh, makes people that should be taken care of by the primary healthcare system are looking for help at private institutions. So there is a point of view here that we have to share, and we have to make it happen so that uh, these policies are not only started but also sustained in time. This takes time, as we all know, but they have to be sustained throughout several government periods. Uh, Sometimes health ministers are in office for only a few months, and that doesn't help. In general, I hope that we go back to a more normal situation in terms of the um, length of the stay of ministers in their position. And I insist there is an important actor, and that's the population itself. The population should demand it and should get involved in these issues. And there should be a consensus about priorities, which is something that we need at the present time. Claudia will tell me I have talked a lot, but I have two more things to say. When the pandemic struck us, of course, there was a great uncertainty. There was a lack of information, a lack of data. There was a great panic, and there is a lot of risk of making mistakes also in such an unknown situation. And after some months in the pandemic, we were already making experiences and developing knowledge, and the countries learn from their mistakes and incorporate new information and base their decisions or try to base their decision on evidence. Those who based their decisions on evidence made it improve their situation more than the ones that didn't. We need a learning process. And what does it mean that ministries should learn from their mistakes? The ministries should incorporate in evidence in an effective manner and base their decisions and their explanations to the population on evidence. This is also something very important. I was very much struck by the lack of capacity in changing decisions during the pandemic and continue insisting on mistaken strategies that were very costly. Uh, we should focus on the general welfare of our population. Lastly, um the other thing that was mentioned here was the issue of efficiency. The efficiency agenda is very difficult. Nobody wants to have it. Uh, to recognize that funds are misspent is something nobody wants to do. But it's really necessary to analyze that because we have to redirect investment based on quality, not only on costs. And linked with this, the last polls, pre-pandemic polls, uh, told us that the countries had lowered the stakes, uh, have, well, that had improved the quality of their services, had a better um, experience of winning again the confidence of the population during the pandemic and after it also. Thank you. This is all, Claudia. Thank you, Midori. Even if, well, you might call me the worst moderator in the world, but I am an economist and I'm very grateful to you, Midori, for stressing the role of the population and to get away from the historic assignation of funds without talking about efficiency specifically and making progress in this sense. Thank you very much for stressing the role of primary health care and of all the innovations that were made during the pandemic and that seemed impossible before and that led us to uh, um, better strategies in time. And now, last but not least, I would like to introduce our last panelist, Oscar Cetrangulo, an economist from the University of Buenos Aires and with a master's degree of the University of Sussex. He is specialized in public finances, and he has been an expert in public policies at ECLAC and a consultant at other international organizations such as the World Bank and ILO. Thank you very much, Oscar, for accepting the invitation. The mic is yours. Thank you, Claudia, for the invitation. And as I said to both Daniels, it's really great to meet old friends. Well, I believe we already heard everything that we needed to hear. We had great presentations and also with the comments. And well, it doesn't really pay to repeat arguments, so I will talk about things that I believe are very important. When we talk about financing, we're talking about the level of expense and the structure of this expense. And financing is not only something qualitative, but also quantitative. Because how do you organize financing and where is it assigned to? And this defines the governability of the sector, the governance of the sector, and who has access to it. And here I believe that an initial point would be about the level. As many of you know, I'm not very comfortable in defining an expense level as a percentage of the GDP, I would say, of the total budget. But as Daniel explained, the diversity in terms of capacities, tax capacities of the region, it's not the same thing for a country with more income or with a higher income than with a lower income. It's not only a question of increasing public expenditure. We agree on other factors, but I believe that the quantitative issues, well, I accept this. When we talk about 6% of the expenditure level, we are putting together public expenditure with other expenditures that are also financed by public resources and go to other aspects of social security. If social security is centrally managed, such is the case in Costa Rica and Uruguay, well, that's great. But if the system is very much segmented with many components, we are not talking about equal coverage here, especially when there are some countries in the region where even in social security, there are clear deficiencies, clear differences in coverage, and not all the population insured receives the same care, which is the case in Peru. It depends on how you pay your own insurance, and this has to do with income, of course, which is the case in income in Chile and Argentina. So I believe that we have to go to a second level of what this means of the present expenditure and what we want to get at. And there can also be other sectors of social protection, for example, in the case of health. And we discussed this many times with Daniel T. In case of health, we should not discriminate, as could be the case in pension funds. We should discuss this. Financing decides how the sector gets organized.
Any type of reform in the health system that tends towards more equal or systems with greater solidarity requires a redefinition of public expenses internally. In many cases in the region, we have seen that systems that are reformed have to reformulate the functions of public hospitals and the old ideas of public provision or the system. And this leads to changes in financing or the direction of that financing. And even more important, in some cases, for countries that are federal or decentralized, usually the bigger ones in South America, we see something that we hadn't addressed yet, and that is decentralization. Here we have a new problem with inequalities in financing when extreme decentralization leads to, even within a country, we have regions that have completely different capabilities in terms of coverage, and we see significant differences in coverage in a country, and this is another factor that we have to consider for inequality. Now, this can only be resolved with a strong role from the central or national governments in federal countries. So if there is a lesson that we can learn from the COVID crisis, is this idea that we have to strengthen the governing capacity of governments and central governments in the cases of decentralized or federal countries. And this is something that is extremely important because this is organized through financing. In situations where you have great inequalities, the one who should be correcting those situations is always the national government. And I believe that it's not just the amount of resources, but also what level of government, how they direct these policies. I think many countries in the region, we're still carrying a big debt, and it's combined with something else, and that is that the networks are not always built in a way that we can easily direct financing from one place to another. Another point that is also related to the role that financing has, financing from the government, is that in the measure that one advances in universal insurance in different ways, as it has been done in the region, and in a progressive process, what one finds is the traditional division between financing and provision. And when one differentiates financing, provision, and provision is in the hands of private agents, there what one sees is a permanent mutation in the morphology of those markets that are becoming more complex. These are markets that have problems in allotments, and then again we see another function that we need to be careful with, and these are the regulations for private markets. In the measure that one can regulate the private sector that provides services to private insurances, to public insurances, there we see a big problem with inefficiency that we have to resolve because resources are not infinite. And this leads us to something that we also heard from the Daniels, and that is in terms of the fiscal space and the need to reformulate taxation policies. There is a point that I want to mention, and that is, in general, one characterizes this region as a region that needs to strengthen taxation because they're a region of low taxation. The improvement of fiscal spaces comes through taxation, but we have to pay attention and we have to see that there are some countries that have extremely high taxation levels, like Brazil, Uruguay, and Argentina, where the taxation is much higher. So the weight of efficiency in resources becomes much bigger, and there we have to work in a differentiated way. So the control of budgetary processes gain a special significance. And from the fiscal spaces, this was also mentioned by Daniel, there is an issue of what taxes finance public activities. In many cases, we have low taxation, but in every case, we have a taxation structure that does not lead to more equal and proportionate strategies. The income tax, for example, are very low, consumption taxes are very high. So you're not just resolving the equality problems, making sure that financing is equal, but we also have to see what general incomes we have in those spaces. So one last comment, and I know Claudia is telling me that we're running out of time, but I want to give one last comment about this, and that is that the priorities, it's essential what was mentioned by Midori. We have to start prioritizing, especially in countries that already have abundant expenses. We have to prioritize. Now, as the population grows older, that is a product of the improvements in health, we see the other competitor for that expenses in public expenses, and these are the pension fund systems. So here we have a complication to be resolved, and that is the apparition of a growing demand of funds for social protection for adult population. That is a consequence of the improvements of the health system, but we have to balance it out. When one talks about the priorities in fiscal spaces, we also have to look at the other sectors to see who we are competing with. And again, to close, I think that if there is one thing that is positive, positive thing that we get out of the negative episode of COVID is the need to reinforce public health and reinforce the governance of national governments. And I think this is an unavoidable step to be able to obtain more equal and efficient systems. Claudia, thank you very much. I don't think I went over my time. Thank you very much. Thank you very much, Oscar. Thank you very much for your reflections and emphasizing on those structural factors that sometimes when we are just in our health sector, we forget, for example, decentralization and informality and how to define the expenses, and of course, considering the other demands, mainly the pensions. I know that Daniel Titelman has to leave, so I'm going to take advantage and have a very quick round of Q&A. Daniel Titelman, the first one will be for you. There's a lot of questions, but I think that we're going to try to pick a few. So it's the following. How do you believe we could get better or more financing for health through taxes in the region of Latin America and the Caribbean if to date we observe a low tax collection, as you mentioned in your presentation, in hand with high levels of informality or informal labor? Thank you very much. And yes, unfortunately, I do have another meeting that I have to go to, so I cannot stay. So I will have to leave after I answer this question. Well, the answer to this question, as was mentioned by the other Daniel, Oscar, and Midori, there is a complex economy and politics in the country. If we want to go towards resilient social protection and health systems, we have to expand the fiscal spaces. And Oscar and Danielle were saying, this fiscal space is not an issue of dogma. It's to how to advance towards fiscal sustainability, allowing us to increase expenses. And this goes through taxation reforms, and this is the economic policy of the region. So we have a low taxation load, and especially a regressive composition of the taxation structure. And at the end of the day, this is a economic policy issue that in how to advance with taxation reform to advance with collections in our country in time, doing it sustainably. And along with taxation reforms, we have to improve the composition of the expenses because, as Daniel is saying, it's not just to increase the expenditure in health, but what are we increasing and what we are spending in terms in having a high private expense is not a good signal, in my opinion. That means that the public system is not doing what it should be doing. And as was also mentioned, this is also an issue of unifying or joining the contributions that come from the general with the general taxes to improve efficiencies in the way we manage financing. It's not just to raise taxation. We have to combine and create a single fund that can bring together the incomes that come from contributions and the incomes that come from general taxes. And informality, of course, is a very important issue because one of the big challenges that we have in the region is how to formalize the informality in these informal labor markets and how to make sure that this informal world participates in the social and health protection systems, and of course also participates in taxation because this is a source of income. Thank you very much. I apologize for having to leave, and congratulations on this excellent webinar. Thank you very much, Daniel. We will stay in touch. Thank you. Here we have a question that I think could be addressed by any panelist, and it refers to the role of civil society. How can civil society contribute? This can be organizations of patients, NGOs, digital influencers. How can they contribute towards the discussion of the need to expand investments in health in the countries in the region? Daniel Olesker. I will tell you about our experience. So why is the participation of society useful in health? So this is the first question that we have to ask. And I think it's important in terms of the design of health policies and also control. I'll refer now to the first one because the second one is generally more accepted. I mean, the social control is important, but I want to talk about design. Why can organized society help in the design of a health system? It can know about the health realities in the territories that they live. Of course, health policies have macro structural policies, and I don't want to waste time on that, but there is a part of the grounded policy of health that is, and in Uruguay, we define the participation both at a national level and also in terms of departments and even local levels. And there is a discussion there. If we have organizations of patients, as Claudia asked in the chat, what is the way, which type of organization is the most adequate? It can be organizations of illnesses. For example, I recently participated in an oncological event, and it had organizations of patients, and these are important. And for this, they have to participate with the public ministry in the design of the provisions for that diseases. And I think that there's a more macro participation, and that is the citizen participation in its representative organizations of being users of health systems. And I believe that this is a key point for design. There are experiences in the world, British experiences. I understand this is one of the most significant ones. And I think primary health care, is where this participation is most relevant because it happens in the territory. This is the more personalized care. So I believe that this can only be done organizedly. You have to have offices where you provide care and where the users go and present their concerns. So I think the incidence or civil society in health policies, and this is valid for education and other social policies, and that is that the collectives, organizations, and they have to have participation in design, and they do this through participation in decision-making organisms. So the participation of users, organizations of providers and users of health systems are included in the insurance. Thank you, Daniel. I have a question for Midori related to the role of primary care and promotion of health inclusion of public health interventions in primary care. How do we incorporate these factors into primary care to impact the costs of caring for chronic diseases or illnesses, and also the sophistication of specialized care through the acquisition of new technologies, etc.? Thank you, Claudia, and thank you for the question. A few minutes ago, I was saying that people usually, well, in some cases, in some countries, and in Peru definitely, people do not find in a health facility, a primary care facility, do not find the solution to their problems. Therefore, it becomes a bureaucratic procedure to be able to get a referral to a hospital. And this is why we have long lines, and well, there's a lot of problems in terms of quality, in terms of how to provide care for the user. So the idea is to strengthen primary care levels in general and provide greater resolution capabilities to this level, and in turn focus or establish basis for populational health. Community health is what I mean. And maybe rethink about the role of the community agents, the relationships with the communities. We are, of course, talking about, we have different contexts like rural, urban, peripheral. So it's difficult to think about one system for all, but the promise of this commitment that the countries have made is to have a primary care level that is both close to the communities and families, and also within the network be able to resolve most of the problems at that level, and that the hospitals, and there's many studies that show that care in big hospitals in a high proportion are things that can be provided in primary care. In places that could be closer to the population. And that is something that is being studied year after year, and year after year, we are not able to see significant advances. I think there's a structure of incentives. The health workers, the suppliers for medications and equipments and infrastructure, all of that, everyone has a sort of incentives towards strengthening the higher levels of care and urban areas. So this is a big change that we have to implement. And I'd like to go back to asking the question of who wants to have that change? Who will be maintaining the legitimacy and the political support for a change of that nature? Political parties are one path. In many of our countries, the political parties are very weakened. So I think that going back to participation, I think that it is important to think about involving the population, and they should be the ones that can clearly express what the benefits would be of a change of this nature and to make it sustainable. I am concerned about reforms that are technically solvent, that introduce changes. I consider correct changes. I would say correct changes, but these are interrupted because of a lack of legitimacy, or the reaction of the population that says, a population saying, don't change this, this is working well. I know that I have moved away from the question a little, but going back to the question, as you were saying, Claudia, innovations in the health sector that have happened because of the pandemic can open up interesting opportunities, and we have definitely seen examples of this. I still think we have to regulate. I think we have to establish the conditions for telemedicine to be taken advantage of with all its benefits, but it can also present problems on losing that contact between the health professional and the person. So how we articulate all that is going to be important. But well, that's all I can say. Thank you, Claudia. Thank you, Midori. And as Daniel was saying, the importance of dialogue, of hearing the different actors in that process of appropriation of the change, and this need to have a primary care level that has a resolution capacity. I have a question now for Oscar. What do you think, Oscar, about the complementarity of the different financing schemes in the provision of services in terms of not duplicating investments, of having greater efficiencies, of course, respecting the change and who wants the change and who's this change is going to benefit. Go ahead, Oscar. Okay, Claudia, let's see. I think that we come from, in general, I mean, I am not trying to overlook special situations, but I think in general, we have a complicated situation in the region. There's a lot of inefficiency in the sector and the health expenses. We do have a lot of duplication, triplication, coverage, fragmentation. All of this has been debated. So each country and each case has to establish the path to change, to improve that. In that path, there are two things to address. One is to improve budgetary issues, improve accountability or policy assessments, but in the public sector. And this means that, and the rest of the sector, that part that is not public, there has to be a notable improvement in regulation mechanisms. I would say that we also have to talk about the regulation of insurances in the private sector. And I think that is very important. A third aspect that one doesn't really mention because it goes beyond what one can do is the need to consolidate those changes into new regulations. Maybe in some countries it would be a new legislation. For other countries, it could be constitutional changes, but this multiplication and fragmentation of systems requires regulatory changes that are not easy. They are hard to negotiate. But I think that's where reform should go. These are always reforms that work with other processes, but I mean, they do have to be proposed. Thank you very much, Oscar. I don't know if James is available for a question. I think James had to leave, so I apologize for having gone over the time. Again, I think that it was worth it. We had guests and presentations that I consider are great. Thank you very much for joining us in this activity, and thank you, Daniel, Midori, Oscar. I'd also like to thank Daniel Tittelman and James Fitzgerald that had to leave the meeting. And I assume the responsibility because we went over our time. And I'd like to thank all of you for your patience and your good disposition to help us reflect. So I think we'll leave it here. There are many things for the future, and the path ahead is a very long one. And we have a goal for 2030, and I hope that we can continue meeting and nourishing this dialogue to see how we can provide more elements for decision makers so that they can make the correct decisions to favor the populations and to address the needs of the populations. Again, thank you very much, everyone, and we will stay in touch. And I'd like to send everyone an embrace. Thank you, Claudia. Thank you.